now like to invite Dr. NEENA to talk about disorders beyond the nucleus, basically supranuclear and internuclear disorders.
Thank you, Ramya and KSOS, for this opportunity. So, my talk is on beyond nuclei. So, as ophthalmologists, we are all familiar with the monocular ocular movements and binocular ocular movements. But how many of us know that there is a triple level of control of eye movements, starting with the supranuclear level, which is the cortex, the basal ganglia, the superior colliculus, thalamus, and cerebellum, coming to the nuclei and internuclear pathways, which are located in the brainstem, where the nuclei of the third, fourth, and the sixth cranial nerves are there, and finally the infranuclear pathway. So the triple level of ocular motility control is very important to understand, because there is a lot of things happening at the cortical level, at the nuclear level, infranuclear and internuclear levels. So the cortical centers, they control when and where eyes should move, whereas the brainstem centers, that is the horizontal gaze center and the vertical gaze center, tell you how your eyes should move. So remember this and you will be able to figure out the eye movement disorders. So this is important because in a multi-speciality hospital, we might be called upon to look upon certain ocular abnormalities. And if you really don't know this, we'll be stuck. So based on this, you can classify ocular movements into fast ocular movements and slow ocular movements, and into gaze shifting and gaze holding eye movements. Like gaze shifting would be smooth pursuits and smooth saccades and vergences, whereas gaze holding is more of the reflexes, the vestibulo-ocular reflex and optokinetic reflex, which help to focus an object of interest into your fovea. So let's talk about the horizontal and vertical gazes. Now, very important that you understand a bit of anatomy here, because without understanding this, you cannot understand the abnormalities. So remember that you have separate gaze centers for horizontal and vertical gazes, and remember that the command for the gazes comes from the brain. So the contralateral frontal eye field gives you command to look to the opposite side. Suppose I want to initiate a saccade to my right, it's my left frontal eye field which gives that command. That is a fast eye movement, whereas the pursuits are usually controlled by the same-sided posterior parietal cortex. That is, the ipsilateral pursuits are controlled by the parieto-occipital cortex. So remember, contralateral frontal eye field controls saccades to my opposite side, and ipsilateral posterior parietal cortex controls pursuits to the same side. So remember, horizontal gaze center lies in pons, in pontine tegmentum. So you have the common final pathway we all have been studying from MBBS days, PPR of paramedian pontine reticular formation, and the nuclei of the third and sixth cranial nerves. Finally, it happens. I'll show you with videos how it happens. So let's look at horizontal saccades, because as ophthalmologists, we check for ductions, versions, we forget vergences, we forget saccades, pursuits. If you're going to write a higher exam, these are very important. And in a neurophthalmic setup, you should know how to test for saccades. So, I'm sorry. So I hope the video plays. Yeah. So this gentleman is shifting his gaze rapidly between two objects which are held across his horizontal gaze eye field, and these are horizontal saccades, fast eye movements which help you to shift your gaze from object of interest. So how does this happen? Suppose I want to look to my right, my left frontal eye field gives a command, and then impulses come down to the contralateral PPRF and sixth nerve nucleus. So remember, sixth nerve nucleus has connections to the same-sided lateral rectus, and it talks to the opposite third nerve via the tract known as medial longitudinal fasciculus. So what happens? The PPRF tells the lateral rectus of the same side to abduct and tells the contralateral medial rectus to adduct. So a conjugate movement happens to the right. So this is what happens when you have a horizontal gaze. This is the pathway for horizontal saccades. Now coming to pursuits, remember P for P, parieto-occipital cortex controls your pursuit. So it's the ipsilateral posterior parietal cortex which controls pursuits. So this is a tracking movement across the horizontal visual field. So again, the pathway is the same, PPR of sixth nerve nucleus via MLF to the contralateral third nerve nucleus, and a conjugate movement is made. Now let's move on to vertical gaze centers. Vertical gaze center is in the midbrain at the junction of thalamo-mesencephalic junction, and 2 nuclei are there. If you don't want to remember, you can forget the rostral interstitial nucleus of MLF and nucleus of Cajal. So again, it is mediated through cranial nerves 3 and 4, so which initiate the vertical eye movements. So the vertical gaze center is in midbrain, and you can look at this picture. This gentleman is looking at 2 objects held across his vertical eye field, and these are vertical saccades. So both frontal eye field has to fire if you have to initiate a vertical saccade, because I said it's contralateral, right? Saccades are initiated by contralateral frontal eye field, but it comes down to the MLF in the midbrain, and then through the 3rd and 4th nerve. Moving to the pursuits, you know it's P for P, posterior parietal cortex for pursuits. Again, it has to be bilateral. And there's a little bit of, complexity here. You have torsional activities. So if you don't want to remember, just forget it. Vergences are also important because they allow you to fixate an object bifoveally. So accommodative vergence happens when there is a retinal blur, and fusional vergence happens when there is an image location disparity. There are vergences areas in the occipital cortex, in the midbrain, and the pons. So finally, the action happens with the 3rd nerve and 6th nerve, which act on the medial rectus and lateral rectus, reciprocally activating and inhibiting those muscles which are involved in convergence and divergence. A word about vestibulo-ocular reflex. These are kind of peripheral controls of horizontal and vertical gazes. What is a simple? Just remember that when you rotate your head to one side, eyes will dramatically, naturally move to the opposite side. This is a basic reflex. How does that happen? Suppose I rotate my head to the left. My left horizontal semicircular canal is stimulated, vestibular nucleus stimulated. It has connections to the contralateral abducens nucleus and to the same side MLF. And again, by the same pathway, there is a conjugate movement happening to the opposite side. So this is what is happening. And it helps to hold the head steady during brief head rotations. So you all know about cows and cup and all. I'm not going into this. Optokinetic reflex. What does this do? It allows us to follow an object in motion while the head remains stationary. So it's a combination of saccades and pursuits, but here you need an intact visual pathway. Is it 8 minutes or 10 minutes? Okay, now cerebellum is a master modulator. It is also important in your eye movements because it fine-tunes all your eye movements. And if you have a problem with cerebellum, you get problems in your saccades, like you overshoot hypermetric saccades, and it has connections to all the important centers. So coming to the supranuclear disorders in a nutshell, you can have gaze palsies, gaze deviations, saccadic disorders, pursuit disorders, vergences, skews, nystagmus, ocular oscillations. I won't be going into all, but a few. So what is conjugate gaze palsy? Let's start with first the cortical disorders affecting the gaze. So gaze can be affected in problems in the cortex. Why? Because your frontal eye field and frontal eye field is responsible for your horizontal gaze, isn't it? So suppose you have look at this video. This lady is having a seizure and she has a gaze deviation to the left because there is an irritative lesion in her right frontal lobe. So the frontal lobe is firing, and so she has contralateral gaze deviation. As opposed to this lady who has a paralytic lesion of her left, of her right frontal lobe, she's unable to look to the opposite side. So her horizontal gaze is paralyzed. So the eyes will deviate to the same side of the lesion. So your irritative lesions will make you look away from the lesion, whereas a paralytic lesion will make you towards the lesion. Now also, it will also help you to localize the lesion. Imagine you have a patient with homonymous hemianopia. You don't know, is the lesion in the parietal cortex or in the, is it an occipital lobe lesion? How do you test? If the ipsilateral pursuits are spared, that means it is more likely to be an occipital lobe lesion than a parietal lobe lesion. That is how you can localize. Coming to conjugate gaze palsy. Now, this is very similar to a 6th nerve palsy, but the lesion is in either in the PPRF or 6th nerve nucleus. The difference is that not only you get an abduction defect, you get a contralateral adduction defect. The whole gaze to one side is gone, horizontal gaze. That is how you differentiate it from a pure fascicular 6th nerve palsy. INO, we all know, is due to a lesion in the medial longitudinal fasciculus. So what happens? On the side of INO, you have adduction defect, and the contralateral side, you have abducting nystagmus. Because what happens here is that the 6th nerve is trying to talk to the 3rd nerve, move the eye, but MLF is not working. So I cannot adduct, but 6th nerve, the PPRF is telling the 6th nerve, move the eye to one side. So sixth nerve is acting, but third nerve is not acting because the MLF is not giving the information. So this is a wall-eyed binocular internuclear ophthalmoplegia. You can see the patient is not able to adduct eyes in both eyes, but is able to abduct with that abducting nystagmus. Convergence could be spared sometimes if it's a posterior INO. You also have other features like, pursuits. And can I take just 1 minute? Yeah. So if it's a young patient, think about multiple sclerosis. If it's an older patient, think about a CVA, a stroke. 1.5 syndrome is when you have a lesion in the PPRF and MLF together, only movement would be the abduction. Coming to vertical gaze palsy, let's start with Parinaud's. Ramya already told you about the arrangement of the third nerve nucleus. Now, in Parinaud's syndrome, there is a loss of inhibitory control of the third nerve nuclei in the midbrain, in the rostral midbrain at the pretectal level. So they fire, all of them fire together. So there is a loss of inhibition. They fire together, and that's the reason why you get the convergence retraction. It's not a nystagmus, it's an abnormal convergence retraction movement, an upgaze palsy, pupillary light near dissociation, Collier's lid retraction, etc. This girl has the typical sunset sign with the upgaze palsy with eyes placed in the down gaze because of a pinealoma compressing the midbrain tectum. Progressive supranuclear palsy is also another condition which will present with vertical gaze palsy. It's very similar to Parkinson's disease, but an aggressive form. But how do you differentiate? In Parkinson's, the vertical gazes are usually spared. Horizontal eye movements become slow. But in PSP, what happens is the vertical gazes are the ones to go first, the up gaze and then slowly down gaze. And patient has a lot of difficulty because of this condition. Typical MRI picture is the hummingbird and the Mickey Mouse sign due to the tegmental atrophy with the preservation of tectum. Parkinson's patients can have convergence insufficiency. So let's go to this last slide. How do you differentiate a supranuclear lesion from an infranuclear lesion? Look for the presence of vestibulo-ocular reflex. So if the doll's eye maneuver or the vestibulo-ocular reflex is intact, you can be sure it's a supranuclear lesion. So that's how you identify this. And this is the last video. This child has a very interesting eye movement disorder. Can anybody help me with this? So look how and I'm giving him a toy and I'm asking him to look at another toy. See what he does. See, instead of making a voluntary saccade, he used a head thrust. He did like this. I gave him a toy and I gave him another toy. Instead of looking at like this, he did like this to shift his gaze from one toy to another toy. So this is because he's unable to initiate voluntary saccades, but he can initiate it with vestibulo-ocular reflex or a doll's eye maneuver. This is a classic case of oculomotor apraxia, which is seen in Joubert's. This case was Joubert's with the classic molar tooth signs. So finally, to say that, remember that frontal eye field controls contralateral saccades. Posterior parietal cortex controls ipsilateral pursuits. Horizontal gaze center is in the pons. Vertical gaze center is in the midbrain. Your vestibular apparatus controls slow eye movements to the opposite side. Supranuclear lesions are usually bilateral, do not usually produce diplopia, and a vestibulo-ocular reflex is preserved in supranuclear palsies. So I hope you were able to understand a bit of it.
Thank you, ma'am. That was a wonderful talk on supranuclear. Very difficult to understand, but you have explained it very nicely with videos and pictures.